TB, programmatic considerations and tools. So if that's what you are expecting, you're in the right place. We appreciate everyone coming. We have an interesting lineup of panelists today with some talks ranging from kind of some theoretical frameworks to consider these issues to the importance of data, some practical tools and considerations, and some country-level examples. So thank you and welcome.
Good morning. I'm one of the chairs this morning. My name is Jenny Nagy. I'm with the TB team in Washington. And it's my pleasure to first introduce the other chair of this meeting, Elizabeth Ployce. She's a public health advisor at USAID TB, and she focuses on program management as well as gender and tuberculosis. So please welcome Elizabeth.
So in my presentation, I will review some key statistics and differences in ways men and women experience TB, identify opportunities to address gender and TB programming, and highlight the benefits of gender-sensitive and gender-transformative programming. My colleagues will then continue and go into more depth by discussing the importance of using gender-disaggregated data, focusing on barriers facing men, discussing the process and tools for addressing gender in programming, and providing examples and lessons from the country level. So incidence. Of the 10.4 million new TB cases in 2015, 56% were men, 34% were women, and 10% were children. The global male-to-female ratio is 1.6 to 1. Male-to-female ratios range from 1.1 in the Eastern Mediterranean region to 2.0 in the Western region. The range on national and subnational scales is even greater, as Charlotte will show. For example, in some areas of Pakistan, Afghanistan, and Iran, they have higher TB rates among women than men, especially for the younger age groups. Mortality. More men die from TB than women, which is expected given the male-to-female incidence ratio of 1.6 to 1. What is notable is that men are more likely to die from TB than women, especially HIV-negative men, at a ratio of about 2.4 to 1. However, HIV-positive women are more likely to die than HIV-positive men, at a ratio of 1.4 to 1. So, what are some factors that might lead to these differences? There are differences in susceptibility and risk. A few examples from the literature are listed here, and these numbers are just citations. You can see some relate to behavior and exposure. Women care more for sick relatives. Men travel more, have more social contacts, spend time in crowded settings, and are more likely to be exposed at work. Men are also more likely to smoke and drink alcohol, both risk factors for TB. Women in sub-Saharan Africa are more likely to be HIV positive, another risk factor for TB. There are also some factors that are purely biological. Women benefit from a more robust immune response. Men have greater lung capacity, are at greater risk of gene polymorphisms, and have higher levels of the hormone hepcidin, all of which may put them at greater risk of TB. Women and men also experience enacted and perceived stigma differently. This is also taken from the published literature, and when findings are specific to one country, that's noted. Both women and men can experience diminished marriage prospects. In many settings, this affects women more, but in at least 2 cases, 2 studies found that it affects men more. Women are also at more risk of experiencing divorce as a direct result of TB. Men tend to worry more about finance and job impacts. Women tend to worry more about social isolation and shunning. Men experience more stigma in the workplace and community, whereas women often experience more stigma in the family. Men are more likely to view TB as a sign of weakness, and that can lead to delay in seeking care. A few examples of other factors impacting health-seeking behavior. Women are less likely to produce quality sputum and are more likely to have extrapulmonary TB. both of which make diagnosing TB more difficult in women. Women's health is a lower priority in some areas. They often have lower knowledge of TB, and they may be financially dependent on family members or require permission or an escort to seek treatment. In some areas, men are more likely to delay seeking care due to financial barriers, conflicts with work, or inability to take time off of work. These are just some examples, and you likely noticed that they fall into familiar categories of barriers to care: stigma, financial constraints, physical or logistical barriers, knowledge or health literacy, socio-demographic factors, or provider and system-level barriers. My point in sharing these examples is to show that both men and women experience these barriers, but in different ways. And to make our programs more efficient and effective, we need to address these differences. One framework we can use to identify opportunities to address gender is by looking at health determinants. This helps to remind us how health is influenced by a wide range of determinants, which can interact in complex ways, ranging from proximal determinants toward the center of the circle, such as genetics and lifestyle factors, to more distal or upstream determinants out the outer edge of the circle, including socioeconomic, cultural, and environmental factors. Gender roles and expectations would also fit at that broader level. By looking at these different categories of determinants, we can identify some entry points to address gendered aspects of TB. For example, we know that tobacco use is responsible for 20% of the global TB burden, and that men, who are 2/3 of those infected with TB, are much more likely than women to smoke. So if you're trying to target men, perhaps an anti-smoking campaign would be successful. Or as I learned yesterday, taxation is the most effective intervention to help reduce smoking, something I don't think the TB community has engaged in. This chart also highlights living and working conditions. We know that minors, for example, who are almost exclusively men, experience extremely high rates of TB, with incidence 3 to 8 times higher than that in the populations from which they come. Also, sex workers are at higher risk of both HIV and TB. This helps to remind us that the physical and natural environments to which an individual is exposed also impact the risk of TB as well as other health outcomes. For example, air pollution can increase risk of both latent and active TB. Socioeconomics and culture also have a tremendous impact on TB. We have all heard and we all know that TB is a disease of poverty. Again, these factors impact men and women differently. For example, if financial resources are scarce and a society values women's health less than men's, then women will have a more difficult time accessing the care that they need. On the other hand, as Jeremiah will explore in his presentation, if concepts of masculinity prevent men from seeking health care, this also needs to be addressed. Another useful framework is the patient pathway. For those who might not be familiar, a simplified pathway of TB patients usually begins in the upper left with symptom onset, progresses to presentation to a healthcare provider, leading to TB being suspected, hopefully quickly, then tested and diagnosed, treatment is initiated, and hopefully treatment is completed and successful. We can use this to help consider points at which intervention might be helpful. For example, individuals need to recognize symptoms. Perhaps if women's low knowledge of TB results in delays in seeking care, education programs that target women might be helpful. If men delay seeking care because being sick is seen as a sign of weakness, perhaps a campaign emphasizing that taking care of one's own health is part of being a responsible family member might be helpful. If men are discontinuing treatment because clinic hours conflict with work hours, adding additional evening or weekend hours to the clinic might be considered. Or perhaps conditional cash transfer programs linked to specific milestones in treatment could improve adherence. In addition, I think there are opportunities outside this traditional patient pathway. Even before a patient is exposed to TB, they have attitudes and beliefs that could lead to a high level of perceived stigma. or they may lack an adequate sense of agency. And this may shape how they first experience TB symptoms, as well as their subsequent health-seeking behavior. On the other end of the pathway, we should realize that many of the psychosocial impacts of TB do not disappear as soon as TB is cured. The individual may still feel shame, may still experience stigma. They may also now be dealing with damaged relationships, unemployment, or side effects from TB treatment. And these individuals need continued support, both for their own health and well-being and for community benefit. For example, if survivors or those still on treatment are assisted in finding employment and are seen as successful with a positive role in the community, this might help reduce stigma and to alleviate the fear that many men face about reduced job prospects or lost wages due to TB treatment. A survivor could also develop a new respected role in the community, perhaps as a patient supporter, community educator, or healthcare worker, benefiting themselves as well as others with or at risk of TB. So the theory is, if we can address some of the determinants of health and improve a patient's journey along this pathway, we can improve outcomes of TB programs. It would look like this: reducing stigma, reducing barriers, can lead to earlier care seeking, leading to earlier treatment initiation, increased treatment success, but also reduced TB transmission, which we know is critical to bringing the TB epidemic under control. In addition, gender-sensitive and gender-transformative programs, which Niyati will define in her presentation, can increase gender equality and increase health equity. So in summary, adequately addressing gender in TB programming can contribute toward the end TB goals, but also can contribute toward making progress toward Sustainable Development Goal number 5, gender equality, and toward the goal of all people achieving their highest standard of health, which WHO identifies as a fundamental right. I'll now turn it over to colleagues to explore this topic in more depth. Thank you, and does anyone have any questions? I think we'll do quick questions immediately after presentation. Yeah. Sure.
Hello everybody, thank you for a very good presentation. The gender aspect of TB is very dear to my heart. I'm Shobha from India, and I have interviewed many women with TB. And yes, men and women both face problems. But I have found in many cases that a female caregiver, she could have been a sister or a daughter who had to leave school to attend to the person at home. And not in one instance did I find that the boy of the family was even expected to leave school. This I'm talking of India across many states. Means I just have qualitative interviews, I don't have quantitative data with me, but this thing came out very strongly. And I do feel that TB impacts women very differently and in a more negative manner, with all respects to men. Thank you.
Thank you very much. I think this is a very good point, and one that we didn't get to in this presentation, and we often don't, is how TB affects families. The individuals, the young girls you were talking about, they aren't even the patients, and yet they are negatively impacted by TB. So there are impacts beyond the patients to the family and the community, and those impacts may also be disproportionately shared by women. I think we'll take most of the questions at the end, but very specific questions to the presentations can be done right after the presentation.
So next we have the pleasure of welcoming Dr. Charlotte Colvin.
Oh, there we go. Oh, great. It already came up. Okay, so thank you all so much for being here today. It's really great to see a full room of folks who are interested in this topic. And I am actually not going to talk for very long. I'm just going to present a few slides that I want to use to highlight the powerful insights that we might find by looking at TB data by gender and sex. Although, as you'll find out from Niyati, I should have titled this Sex and TB Data. So without further ado, just my conflict of interest disclosure, I don't think I have any. As many of you probably already know, TB prevalence surveys have become a really important source of information for us in terms of understanding the dynamics of the TB epidemic across the globe. And since 2009, there have been about 25 surveys done in high burden settings. And one of the things that's really fascinating is that one consistent finding across all of the countries, across all of the regions, is that men have higher prevalent, TB is more prevalent among men. And you can see in this graph, we have the smear positive and the bacteriologically confirmed. If you just look at the red dots, in country after country, we see that the ratio from men to women is high. And if you look at, for example, Uganda, we see that it's quite high, 4 to 1. So I find this very interesting, and it's also I'm quite involved with some of these surveys and supporting some of my colleagues who actually implement them, and they will also tell you that in these surveys, men are much less likely to actually participate in the survey. They have participation rates are quite low, and particularly among young men in urban areas, which is something I think we can learn from. Okay. Also, if we sort of look at the prevalence survey data and the notification data together, we find that the detection and reporting gap is higher for men. So basically what this means is that of the women who have TB, we're actually finding more of them, and we're losing more of the men. And if you look at the orange dots representing the prevalence to notification ratio, it's higher consistently for men across countries. And this is also data that are generated from the prevalence surveys and then compared with notification rates. So if we kind of progress from prevalence surveys down to TB notifications, in 2015, so this is all from the 2016 Global TB report, which came out last year. So what's great is now 98% of countries reporting to WHO each year are providing their case notifications by age and sex. And this is a huge accomplishment because even 10 years ago, there were still many high burden countries who aren't submitting these data by age and sex. So this is really great. In 2015, if we look at the high burden countries as they were defined in 2015, the male-female ratio ranged from 1.1 in Pakistan to 3.1 in Vietnam. One interesting and sort of next frontier that I see for these data is that we don't yet have routine data on TB HIV co-infection that originates in the TB clinic is not available by sex, and I think that's a really important next step. So this is sort of just a different way of looking at the graph that Liz has already presented, and basically what we're looking at here is I want you to focus on the orange, which is the men. So if we look at TB case notifications by age and sex in 2015, both globally and for WHO regions, we see a consistent pattern. I think it's particularly interesting to look at Southeast Asia and Western Pacific, and we'll talk about this a little bit more when we look at the data from India, that the ratio really goes up with age. Africa, what's interesting there is we do know from some of the demographic analysis that's been done that the higher the HIV prevalence, the closer to a 1-to-1 ratio you get between notifications and prevalence between men and women. So that's sort of reflected here. And then down here at the bottom right, you have just globally, which I think is pretty striking. So I'm going to just spend the next 2 slides are a little bit of a simple analysis of India's TB case notifications for last year. And I don't know if anybody from the India NTP or any of our colleagues who are working in India are in the room, but they really should be applauded. Because they're now not only reporting to WHO in this way, but if you go online, they have state-level age-sex notifications, and it's available to the public. They put their annual report online, so it's really great for people who are interested in digging into these data, and I think they should be applauded for for doing that. So this is just a really simple analysis looking at the sex ratio among age groups from between females and males. And what's really sort of interesting, again, is this pattern with age, where as the older the age group, you just see consistently more men being diagnosed or reported. And then, just looking at the male to female ratio, it's very clear the overall is 1.9, but the older you get, if you're a man, the higher at risk you are, because we see that, at 65 plus, it's 3.4. So I think, I'm not a clinician, but I think one of the interesting things about this is this opens up a lot of questions for us. And I think that looking at just these very simple graphs and data it helps us start asking questions we might not have asked before. So I find this fascinating because it's a somewhat old article, but I think it's a really powerful article that was published about sex difference in tuberculosis in Afghanistan. And so Afghanistan is a country where I'm sure everyone knows, we know the gender barriers are very clear. We know that there are very specific barriers to care that women face in seeking care for any symptom, much less TB. And yet, consistently we see in Afghanistan that the female to male ratio is quite high. And it's also similar for Pakistan, although in Pakistan you have very wide provincial variations. So I think, again, the question that comes up for me is, so we know that in many other settings it's higher male to female. We know, and we sort of have some assumptions about what might be causing that. We also have assumptions about what barriers to care are. And then we look at a country like Afghanistan where the barriers to care are actually quite clear, but the epidemiology is looking quite different. And so what kind of questions does that lead us to ask that would then help us to design a better program? And then this is actually my last slide because I want to cede most of my time to the remaining speakers who have some really more interesting insights. But I think other considerations is, again, I think TB, HIV notifications by sex are going to be really helpful, by sex and age are going to be really helpful, particularly in the African region. I think looking, remembering what Liz was saying about the prevalence of extrapulmonary TB among women, I don't think there are very many countries that we can really break down the site of disease by sex, and I think that could be really helpful in some countries and help us understand better who might be missed and how better to treat them. And then also, my personal interest, and I think this is also related to barriers to care, is when we look at diagnosis by sex. So one of the things that we're increasingly, as we see the spread of expert, as we see the spread of new technologies, we have countries who are really trying to shift from clinically diagnosing TB to having a bacterial confirmation. And I personally, feel free to disagree with me, think it would be sort of interesting to look at these patterns as we have more and more data from platforms like DHIS2. We could look at the age-sex distributions of these bacteriologically confirmed versus clinically diagnosed cases, and that might give us some insight as to who has access to the bacteriological diagnosis, who doesn't have access, and maybe help us think through how we could adjust our programs accordingly. So that's all I have. I want to hand the rest of my time over to my colleagues. I could take a quick question or two if there's clarification, or we could just wait till the end. Are there any quick questions of clarification? Okay.
Thank you so much, Charlotte. I'd next like to welcome to the stage Dr. Jeremiah Chikavori, who is a sociologist with a public health background. He works in the Human Sciences Research Council in Durban, South Africa, and has a special interest in men's engagement with health issues and how this is shaped at various levels of social organization and processes. Cede the floor to Jeremiah. Thank you.
Okay, morning. I'm going to talk to you about masculinities and TB. And I think in terms of the gender distribution, my colleagues have already highlighted some of the manner in which the distribution occurs. So, yes, we have the picture in terms of how TB is distributed, that men are more likely to be diagnosed and to also remain undiagnosed in the community, and also that they have higher and earlier mortality than women. So this is part of a broader picture in which men have greater and earlier general mortality than women, and also men don't utilize healthcare as much as women. I think this is very much described in the literature. So into this space, masculinity conversations have tried to unpack, to understand why this situation is like this. So there has been quite a lot of writings, sociological writings, trying to raise debates around why men do not access healthcare as much as women. And of course, this leads us into the policy arena, and there has been some focus on and critique on the approaches used and also the underlying principles. So in my talk, I'm just going to try to reflect on what needs to be done, given we have this picture that we know, what possible steps could be taken, who may be involved, what should be targeted to be changed, and what are the potential major challenges along the way. I will start by just reflecting on some of the things that have come out of the literature. For instance, we see in the literature that health facilities are seen to have challenges. There's been description that the health facilities are perceived as places where people go to die. There's also a description of how there is poor communication of algorithms, people being forced literally into procedures with little control and with little information about what they are being asked to do. Issues about lack of courtesy and respect regularly come up in the literature, and we are aware that sometimes that is emasculating to men. The long waiting hours, which inconvenience men in different ways than women, and noting, of course, that women have also huge responsibilities. But what we're trying to emphasize is that men and women have different challenges, and I think this is what we need to acknowledge. And what has also come up, which has been published, is the issue that men feel that there is lack of dedicated spaces for men at facilities, unlike women and children. And this arises from how our healthcare facilities have been set up mainly as ANC centers, so that men don't feel that they have room or they can access as easily as women. I'll just show you a few quotes, and these are from published work. I've been involved in this work, and it from 2010. So here, a man is saying, the stuff is just rough. The last time I was there, I wasn't feeling well. They said something that I just couldn't understand. They said, you are the problem. After doing your things out there, you come to us coughing and almost dying. Imagine I'm in pain, and then someone speaks like that to me. And I think what is important to note in that quote is the fact that men describe that I am in pain, I'm almost dying. And this is not what we normally discuss men as. We normally look at men as showing strength, resilience, and So the other one says, when our child died at Hospital X, one of them grimaced, and as I approached the reception, before I even knew my child had died, that affected me so much. When my child and I emerged later, they continued laughing. It disheartened me. Up to now, no matter how ill, I will not go to the hospital. I would rather stay at home. So there are also issues that are coming up in terms of workplaces. There's been some literature published recently that indicates that there is a perception that they are not dedicated and comprehensive TB education. There is no dedicated and comprehensive TB education provided, including in places such as mines, and also that there is limited protection of workers' rights and policies. Of course, most companies do have policies that seek to protect workers, but in practice, workers don't feel protected. And when workers are found to be infected, then in some cases they feel that they are offloaded rather than retained. In terms of workplaces, we also see that they do not offer security to allow people time off to engage in healthcare. And this tends to occur especially where there is high unemployment and so workers' rights are less protected. And where there is high unemployment, we also see high informal rates of employment. Men are also concerned about the opportunity loss that is associated with missing work. This quote is saying that you can see a person's cough has gone far, and this is talking about meanings that are given to cough. You can see that a person's cough has gone too far, that they must now seek treatment. You can tell from the sound of the cough that it's like someone is suffering from HIV. The ordinary cough is just a once-off thing, but it's at times when one coughs persistently. When a person coughs with HIV, they end up crying due to pain from the cough. So you can see that there is also limited information, and people can try to deduce what their cough is being caused by. And this other man was saying, one of my friends said, smoke a lot, the cough will go. Others would tell me to take a lot of brandy. I did that, but my cough actually worsened, and some of my friends began to advise me to stop smoking and drinking. And what this is showing, and I think this came out in Liz's talk, where she was talking about, men being more likely to drink, to smoke. And this, we are seeing how men encourage each other as well to engage in those behaviors, in the process delaying engagement with healthcare. Now, there's something that I think we can call resistance or actions, and this is when men behave in different ways that we normally expect them to do. And there are studies that have shown that men are indeed concerned about protecting their families, and some men were describing how they feared, after learning that they had TB, they feared sharing utensils, because they felt that they risked spreading TB to their families. But also men, if you recall the earlier slides, men also report emotional and physical, what I can call suffering, and feeling isolated and stressed by incapacity to work. And this came out in work that I've done in Malawi, where men were really very worried about what having tuberculosis would imply to their ability to continue to provide for their families. So in that sense, men may feel that they are in a way vulnerable. And again, we don't normally associate vulnerability with men, but this is increasingly coming out in studies. Just following up on the theme of resistance, this man was saying, I never used to know peace before. Whenever I tried to sleep, I would start coughing, and then I would have to sit up. And there was the breathlessness, so I'm very glad the diagnosis happened while I was still strong, and I could take the drug and not be severely weakened from it. The other man is saying, upon receiving medication and instructions, on the way home, my wife told me, this is your chance. Now you can be chaste. And then he continued, whatever she tells me, for example, you will not leave this house, you should first have a bath, I will obey. But what I'm trying to highlight there, again, pursuing the theme of resistance, is how men shift. And if we look at men as essential, then we sort of miss that window, that possibility, that node where we can grow the ways in which men can be facilitated or helped to pursue the behaviors that they would want to pursue. The man who was describing how he suffered first, and then now he was happy that he was strong again. That's a major change. So I'll just move on to some of what I think are issues that we can consider around interventions. I think the area of interventions is very broad, and I wouldn't be able to cover that in a short talk. It is very complex. So what I'll just do is to highlight some issues that I think we can reflect on. For instance, I think there is need for health system strengthening to accommodate men and engender a respectful and a collaborative atmosphere. But also we need to focus on workplaces in their diversity. I think when we talk of workplaces, maybe we think about formal workplaces, big companies, but men all over the world work in various places, informal, formal, some of them with protection and social security, some of them without. We need to consider all those places and tailor our intervention so that we are able to reach those men in those places. But also strengthening social security and reducing exposure to out-of-pocket expenditure. This has come out as a sort of major issue in terms of access to health. And for men especially, the implications of being ill and being unable to look after one's family, which is an expected responsibility in most settings, can actually be very stressful to them. So I think social security is something that needs to continue to be strengthened. And of course we need to also look at, and this looks like it's very basic, continuing to strengthen knowledge, but if you have people thinking that you can tell cough that is HIV related from cough that is not HIV related, then I think that indicates that there's need for much more information, because then even whether there is cough that is HIV related is something that ought to be debatable. But also that drinking and smoking can help to kill off a cough. All those are knowledge issues, and that they need to be addressed. Okay. And of course, that to acknowledge the instances of resistance where men act differently than is often assumed, and building on those. I think this needs to be stressed, because in many cases, men are looked at negatively. A very common line that one hears is that men are a problem. This is how men behave. And by stressing that, we miss those men who are committed to looking after their families, who are committed to wanting to improve their health and start to function again. So I think that it's very important that we give due recognition to that. And of course, recognizing the special vulnerabilities of men and women. And I think it speaks to the issue that came up from India, from the question that came earlier. So we need to just acknowledge that men and women have different vulnerabilities, but we need to attend to them in different ways, also realizing that they influence each other. And that goes to the last point, where I'm saying that we acknowledge that men and women co-construct each other. Women are instrumental in shaping the form and manifestation of masculinity. I'll just show you a couple of quotes to that effect. So here, the quote above is saying, like most things we should assume, this was a woman, we should just assume, well, what I wish to be doing in the family, I mean, being employed, right? Because then it means that what I expect of him can be done. Basically, it's a woman who is saying that we expect the man to provide for the family, and she can draw pride from that, and we can budget for this and that because money is there. Now, The next quote is saying, this is now a man who was describing how he feels or how he'd feel if he wasn't working. And men were saying they feel that women discuss about them in sort of demeaning ways. And he was saying, the friends will tell her, why do you have to suffer with an unemployed husband and the marriage? Another man can marry and make you happy. I'm just bringing this cause to show how men look at how women think about them, but also how women construct men. And I think I'm stressing that gender should involve looking at how men relate with men rather than looking at those two sexes separately. So I have done work in Malawi, and during the work we had a workshop with stakeholders, different people. People were living with TB, people were from the health managers, healthcare providers, and ordinary people from the community, as well as TB patients. And in the workshop, we're trying to come up with what are the possible interventions that we can think about or implement. So this green slide is showing you what came out of that. And it was specific to Malawi, but some of the issues that came up, I think, can be applicable in various contexts. And it repeats some of what I said. We need to train health service staff to become more aware and receptive of men's special needs. We need to dedicate days for men during outreach activities, setting up mobile healthcare vans so that men can be reached in the different places that they congregate. Enhance household income, which is enhancing social security, so that people are not exposed to the effect of, to the challenges that are related to seeking health care, but also not being able to function when one is not well. Enlisting corporate involvement, and this is the workplace, so that people are supported and they can be enabled to seek care when they need to. Those are some of the issues. And of course, there was a need that was mentioned for the healthcare system to engage more with the community, because there seemed to be a lot of distrust, and that distrust was felt to be a barrier to seeking care. So I think I'll just stop at that for now. And I just would like to thank for conference support KNCV Netherlands and all the Wellcome Trust who funded most of my work, my collaborators. And thank you so much.
Thank you so very much, Jeremiah, for those important insights on men. I know that's an issue that we don't talk about enough, and I think it's a really important one, especially in the TB community.
Thank you. So great to see such a packed room. So I'm going to be talking about specifically gender and programming. So we have some information, we have data, we have some knowledge. How do we move forward and actually integrate that into either our research or our program design? So I'm going to be talking about the role and impact of gender on health outcomes, why we even address it, looking at a couple of tools. There's a gender integration tool, and also the importance of doing a gender analysis, then applying those results to your design. And then key resources, just a snapshot of resources. There are many that I think could be helpful as you embark forward. So as Charlotte mentioned, I think it's really important that we have a shared vocabulary of terms and one of this basic terms that still sometimes can be sticky for people is the difference between gender and sex. And the point I want to drive home in this slide and these definitions is that sex is really looking at the biology, right? Is what you're born with. And gender are socially constructed roles that are culturally defined, that change over time, and they're deep-seated. And a quick anecdote about this, I do a lot of training in one of the countries I was in. The Minister of Health popped in and surprised us. And one of the exercises that we do is actually on gender and sex. It involves everyone getting up out of their chairs and moving to one side of the room if they think a statement is talking about sex or gender. And the Minister of Health moved to the incorrect side of the room, and my colleague said, "Oh, she chose the wrong side." And I said, "Actually, it's a teaching moment." And the phrase was, men are tough and strong, women are gentle and emotional. And so I asked her, is that the way women and men are born? And she's like, "Well, yeah." And I'm like, "So biologically?" And then she kind of looked up and she said, "Oh, okay, I need to change. I need to think about this, So it affects all of us, no matter how long we've been working in this field. We make assumptions, we have biases, so it's really important to address them. And transgender individuals, I would say, also not only face similar barriers, but oftentimes exacerbated barriers because of their unique expectations that they're put against. So gender equality and health. Why do we work on this? Because gender equality, as we've seen from the previous presentations, helps to, when we address gender equality, we're helping to reach our health outcomes, but we're also advancing equality and the value of men and women, boys and girls as equal to each other. Not only at the individual level, the workplace, at the community, the household level as well. And this slide I put up here also because similar to the gender and sex discussion, often we'll see programs that say, well, we're working with women, so we're working on gender. No, you're just working with women. So while gender equality is very important to women's health because often they are vulnerable populations, it's also important for men's health. And this is some of the work that we've seen a lot of work happening in the HIV community and the family planning community to address positive masculinities, to work with women and men together, men as users of health services, men as supporters, men as equal advocates as well. And then gender equality also impacts other gendered groups as well. So really taking that into account when you design either research or a program, who are your beneficiaries? So it's really not about who, but how you're addressing your program. So you take the who into account, but looking at the how piece as well. So just a quick outline of what we are doing at USAID. We have a policy that was launched in 2012, and it looks at advancing equality between women and men, boys and girls, across all of the sociological models, so from the individual, household, community, institutional, and also empowering women and girls because they are the more vulnerable population. But then we also, that I would say is our umbrella strategy, but we also have a number of other policies that kind of fit and support the gender equality strategy, including looking at child marriage, trafficking, human rights, democracy, women, peace and security, which we just passed, which is quite exciting. And then we have a special module, ADS 205, which actually goes into how you address gender equality in your health programming. So the first tool I wanted to talk about is the gender continuum. And this tool was developed from the Interagency Gender Working Group, which is a consortium of government and implementing partners that came together. So it was a very consultative process. I'll start with the top. The blue box is where we're gender blind. So we are not looking at any of, in a given community, the roles of men and women, boys and girls, what they do, what they're expected to do, how they're expected to act with each other and in their own communities. So we never want to be gender blind, essentially. When we're gender aware, we take time to look at and see what are the barriers that are in a given community that are gender related, whether they're social, economical, political. And then we design a program. And when we design something, it can inadvertently end up in the red zone, which we again don't want, which is exploitative, where you're seeing that men can be thought of as strong, and so you create a program that exacerbates that. Men be strong, do the right thing. You're really not creating a program that's advancing equality. You're exacerbating a gender norm. You can be accommodating, so you know that there's barriers, and some of our colleagues talked about this. You can bring the services to the people if they can't get there. There's norms that prevent them from getting to a clinic. Women can't leave the house, so we'll bring healthcare workers to the community. Or you can create a program that's more transformative in nature, where you're really addressing the gender barriers. So this involves usually a lot more time commitment, some more monetary commitment, but a more sustainable way of moving forward, because you're not only advancing TB outcomes, but maybe other health outcomes, economic outcomes, social outcomes as well, to reach our goal. And the one thing I'd want to say about this continuum is that it's just that. So programs don't necessarily neatly fit on one point of the arrow of the other, and sometimes they move back and forth. And we like to promote designing interventions that might be mostly accommodating, but planting seeds of transformative interventions if possible. So it's a great conceptual framework as you are designing a program. Some key principles: do no harm. As I mentioned, we don't want to be exploitative or exacerbate existing gender norms. We should always be aware, so we should be creating program designs or research that are based on data and information that we have. And again, they can move back and forth on the continuum. So a few examples of programming. As I said, family planning has done a lot of this work, and they had a billboard, play the game right, be a man, wear a condom, right? So what's wrong with that? Did you get men to use more condoms? Sure, maybe, but did you exacerbate that norm that our previous colleagues were talking about of men being strong? And so you take away that opportunity for men to talk about positive masculinity and household decision-making together with their partner, because it's in relation to their partner where family planning takes place. Gender accommodating, there's a number of examples, but as I mentioned, community-based distribution of contraceptives for women. There are examples that we've seen in the TB community as well of bringing services to the people that can't leave their house, whether it's because they're too ill or more often than not because there are some social norms that prevent them from leaving the house, or stigma that prevents them from leaving the house. And then gender transformative small group discussions with women, adolescents, and youth, specifically talking about gender norms. And the reason that's transformative is that you're creating a safe space to talk about some of these issues where, as in the last presentation we saw, men are human beings. They have emotional needs. They can feel isolated. Is there a forum for them to talk about this where we can start to break down some of these barriers and norms and include women? And when we have workshops that we're talking to women, include men. So really being mindful that when we do sensitization work that we're really including both men and women, especially as it is in relation to each other. And then finally, I just wanted to go over a gender analysis. So we do a gender analysis to help inform research design or program design. And it's really important to look at, there's a number of ways you can go about it, and this is kind of our USAID way, where we look at 5 domains. So we look at laws, policies, regulations, and institutional practices. So some questions you can ask are men and women treated equally by legislation? Is there legislation to equally protect men and women? How would this potentially impact what you plan to do? Cultural norms and beliefs, looking at what beliefs and perceptions shape gender identities, such as it's not considered a manly thing to do to go seek care, for example. Is that what the community believes where you're working? Who does what, where, and why, right? So this is critically important when we're looking at women are oftentimes the major caregivers in a community. So if you're asking them to join an income generating activity, who's taking care of the children? So taking into account the realities of how people are living their lives. Access and control over assets and resources. This is an important thing to look at as well, is not just who has money, but who controls it. How are those decisions made? Who benefits from resources as well? And then patterns of powers and decision-making, which I think actually cut across all of the domains, is, again, looking at decision-making, influence, and not just at the household level, but also at the community level and beyond. Oftentimes we have, luckily now, many of the places that we work, we have gender policies that are national, but do they trickle down to the subnational level, to the community level? Are people aware of these powers that they can utilize as kind of contracts of human rights frameworks? And then a few resources we have on the Interagency Gender Working Group. There's actually a really wonderful guide on how to manage and conduct assessments, gender assessments, and social inclusions assessments. The Stop TB group developed a gender and HIV assessment tool, which is also really well done. And to borrow from our friends in the HIV sector, they've done some great work on gender and HIV, where you really can look at indicators and ways to measure change over time, which is critically important as well. Additional resources from, I just want to point towards the bottom, and Gender Health has done some really good work in engaging men as partners, and Men Engage as well, which is a great global organization that's working on addressing masculinities and positive masculinities. That's all. Thank you.
Good morning. Thank you all for showing up for this important session on gender. I would like now to sort of introduce to you what we have been doing in Tanzania in regard to gender integration to TB program. We have heard a lot about on how gender can be integrated, on how you can do analysis and use the data you have, but now this is the practical experience and lessons learned of which we have observed in Tanzania. I'll take you through the country profile and then on how gender is integrated, the tools we have used and some results, and also the lessons learned, and of course the recommendations. And finally, I'll acknowledge people who have assisted me in putting up everything. The blue dot there is the Tanzania, the land of Kilimanjaro. It's in the Eastern Africa. As you see on my right side, of which, yeah, it's your right. This is the battle, the war we have been up to when we talk of TB. The top left graph is the mortality rate, of which we have been experiencing since we have been, in the TB programming. It's kind of going down, and the general picture or the incidence is decreasing. The middle graph, as you see, I don't know if it's clear for those people sitting at the back. The black line is notified cases. When we talk of new and relapses, it's kind of stagnant. But when you talk of incidence, is going down over the years. And the bottom graph is on the treatment outcome, on the treatment success rate. For the blue one is the new and relapse cases. It has been going up. And we have some MDR-TB outcome, of which do not show a very good picture, but this is something which can be explained on. Digging down to the recent report on notification in Tanzania, we have managed to notify 62,180 cases in 2015. And the treatment coverage is around 37%. So you can easily see that we are still losing some patients. We're still missing some people with TB. On the right-hand side is the graph of the notification, of which shows the age and sex on the 2015 data. You can easily see that the most affected group is the group of which is 25 years to 44 years, and most males, again, have been affected largely, on a large extent. So, introducing Challenge TB to you, this is a flagship project which is funded by USAID. KNCV is the main partner, as most of you might know. It is aligned with the post-2015 global TB strategy and informed by the newest government TB strategy, as my colleagues have pointed out. And also, most of the activities in Tanzania, when we talk of Challenge TB, they look at the gap analysis which was conducted in relation to what is on the ground and what's supposed to be done. So one area of which we thought of addressing is the gender issue when we talk of TB programming. In Tanzania, we have as you know, Challenge TB has 9 partners, but in Tanzania we have 2 partners. These are PATH and ATS, American Thoracic Society from the US. So integrating gender and Challenge TB, we used a process of which NIET have sort of tried to put up. Before we started, implementing activities, we had to do an assessment and analyze some routine data which has been collected from the field, so as to get a better understanding on how big is the issue, and which then would inform the policymakers and the decision makers, planners, or different implementing partners. So in this assessment, we are also looking at what are the roles and responsibilities. Is there inequalities, inequities, when we talk of gender in TB programming? So after that, you get to know what is the situation, and then you come out with an intervention with a specific focus. In our case, after the analysis, we had to target different areas, mostly to find the cases, and at the community level, and at the health facility levels. So when we talk of the health facility levels, the intervention mostly are directed to different departments. When you talk of the health center, if it's an hospital, we target the reproductive and child health. You target the care and treatment clinics. You target the in and out outpatient wards. So you kind of have a comprehensive approach to that particular strategy. In the case of the community, we have different interventions, of which I'll speak out later, of which we had formulated some strategies on that. So in a nutshell, it's kind of a sectoral approach, of which would be to assist the intervention so as to capture a large number of people who are being targeted in that. The design of the project, as I've indicated earlier, was to focus on the health facility level for those people who are coming to the site, to the health facility sites, and also have some interventions in the community. So we're not leaving the community to be on their own. So we have interventions of which we designed that on how we can approach them and make sure that they access the services and they get the services. Also, the engagement of key populations. In this case, we have on the community side, we have the mining communities, we have the people who live with HIV, people with diabetes, injecting drug users. These are all key populations of which we took into account when we're designing this. So in the end, you have everything in place. You have strategies, you have activities. You have to monitor them to make sure that what you have focused on, you are really assessing on how you are performing. So we do a lot of evaluation to see if the interventions are effective, and demonstrate if the program objectives are being met or being achieved, and also identify if there are some gender-related constraints. And this should be frequently so that you know on how to redesign your approach. So what we have observed in Tanzania and most of the countries do not have country-specific policies or guidelines addressing the gender programming in TB. So the gender programming in TB is taken as a cross-cutting issue, meaning that it is integrated in general services, whether it's in the community, whether it's in the health facility, but it's not that much specific to TB. That's something which is missing. And as I said, Challenge TB, after having all that on board, the information we had, we rolled out the active case finding activities at the community level, and also we had active case finding in the facilities. This involved a lot of trainings when you talk about the facilities to create more awareness on the gender-specific roles and responsibility, to create more awareness on the importance of collecting the gender-related data, so as to have an information which can aid the policy and the decision makers to improve the services. So at the health facility, as I said before, we managed to sensitize and introduce the services on different departments, mostly on the reproductive and child health and care and treatment. This is our HIV treatment centers, and also in different departments at the health facility. You can easily see that the men are left somewhere, as my colleague Jeremiah noted that. So this is something of which, again, we should think of working on so as to improve the situation. At the community level, as I said, we have interventions targeting mining community, people who inject drugs, fishing camps, congregate settings. Now we're talking of the prisoners and schools. We have volunteers of whom we train. We train on how to provide the education, on how to raise awareness on TB, and hence, motivate people to go and screen. Because we would see that these communities are more on key or vulnerable populations, of which we think that they might be affected more when it comes to TB. Another intervention of which we have instituted is the supportive supervisions and capacity building activities. So we have supportive supervision to these areas who are implementing these activities. And of course, as I said earlier, collection of information and data and continuous analysis on how the program is performing. And also we have a mentorships, face-to-face interventions, or the utilization of the performance review meetings. This is where the coordinators whom we are working with come on a quarterly basis. We sit down and see how the program is performing, looking at specific intervention, of which one of them is the gender-related issues. And also through the training of the healthcare workers, we have tools of which I will introduce them to you with the next slide, I think. We had an issue of introducing these tools. I'm saying this is an issue because these are the tools which are now capturing new data, capturing new indicators of which these healthcare workers were not used to. So, change management has to be taken on board. And we have already seen some challenges on these tools that they take a lot of time in filling them, but again, what we gather from them is really helpful in improving the program. So these are the tools. Mostly are the TB recording and reporting tools, and these have been advocated by Quality Improvement Toolkit, of which was developed by the support of the Global Fund for increasing the TB cases in Tanzania. We have them at the community level and also at the health facility level. At the community level, as I said, we have interventions of which raise awareness and then create a linkage to the health facilities. So there's a sort of referrals from the community to the health facilities. So we have a form at the community level which gather the, collects the information of that particular person who is going to, to be screened after having probably an awareness session. And also that form is being translated into the registers. Again, this is still at the community level. So we have community healthcare workers or volunteers who are working towards making sure that these forms are really filled properly so that we monitor that the gender issue which is being implemented at the community level. At the facility level, we have what we call, this is the new register, presumptive register, of which I will show you after this slide. It's new because it has a component of the presumptive people. We used not to have this in Tanzania, but now we thought due to the quality improvement toolkit, it's good to show how many people who are presumed to have TB access the service, and how many of those access the service get the test. So in that way, you look into how accessibility is being approached when you're doing programming. So we have these new registers, and of course they are translated later into unit register. This that facility, that particular facility register. All these registers, they have the gender desegregated. They have a female and male component. The last one is also the pediatric TB screening score charts. We reintroduced this. This was in line to increase the case in the pediatric population, to increase the TB notification in pediatric population. So it has helped a lot in raising the cases in pediatrics. And the other tool of which we use the checklist, the supervision checklist, as I pointed earlier, that in this intervention you have to have a monitoring system of which we use the supportives as provision. Previously, this checklist did not include issues which are related to gender programming in a specific population. For instance, the congregate setting. For instance, the different hospital departments. It was only going to the TB clinic, you finish up your things there, probably you go to the lab and some departments, but not all over the departments. So this tool also has been updated so as to make sure that it captures everything which is related to gender. And also, we have been advocating the utilization of gender assessment tool for the national TB and HIV responses, of which my colleague pointed out as a reference to be utilized. We have utilized this tool during the Global Fund concept write-up, and also in different country national strategic plans. When we talk of HIV strategic plan, when we talk of TB strategic plan, we make sure this tool is being used so that it makes you think of gender integration in whatever you're planning to do. Lastly, also we're advocating to different partners. Kenyan CVO Challenge TB project is not the only TB partner in Tanzania, but also there are some other projects of which are dealing with TB as well. So we have been trying to advocate they use this tool so that they don't leave out the gender component of programming. So these are some of the tools we have been using. These are new tools. This essentially is the register at the community level. It is in Kiswahili, apparently, but I can translate the fourth column. That's where we capture the gender of the sex actually of that person. The first column is the serial number. The second is about the date. The third is the name. So you have the name, after the name you indicate the sex. This is at the community level. So we train the volunteers or community health workers, to fill in properly on this so as to make the report out of it. Even the report, the left one is the referral form. Once you have a presumptive person in the community, you have to refer that person to go to the health facility. So we have two interventions there. Either you refer the person to go to the facility, or we have a group of people, we call them sputum fixers. They fix the sputum specimen of that particular person and then fill up this form. It goes with their sample or the slides to the diagnostic center. And then on the monthly basis, hence the quarterly, we have the reporting on the far right, which also has an indication of sex, male, female, male, female, male, female. Sorry, this is a bit clouded, but this is the adult and pediatric presumptive register. It's new as well, so we are doing a lot of supervisions and to make sure that all healthcare workers are oriented on this. This register is different from the normal register we know. This register is supposed to be in every department at the health facility so that you get all the presumptive people in this. Essentially, the female and male column is there to indicate the intervention of which we thought that we can make a good information out of it. So this is placed in every department, and at every department we have a focal person of whom is responsible for this, making sure that it's filled properly and then reported timely. There are some challenges related to this because it has created more workload on those healthcare workers. So you really need to work with them and make sure that they understand why are you collecting this data. So the results, since the inception of this intervention, there has been a notable increase in notification since the commencement of the project. The project started in 2014, but we started the actual implementation in 2015. So we've seen that more men have been notified, and mostly in the age group above 45, of which is in support with results of the prevalence survey in Tanzania, that the TB prevalence is more in the older adult age. We have seen that there is no significant difference in the TB outcome between the males and females. I'll show the slides later. But of essence, in this active case finding of which I've described, we have seen a female access more services than men. Now, this reminds me of a question of my colleague from Kenya on last Sunday, where she was saying, we need to find men. So even the access, females are still accessing more services. The results might not be that much conclusive, but it shows that there's a difference on that. And of course, there has been a remarkable increase in pediatric TB notification. So these are the results. You can see the data is from 2014, 2015, and 16. The green ones are the 2016. You can easily see that the age group between 15 to 44 is the one which is highly affected. But again, if you look at the males over 45 years, the numbers are increasing. So again, this is in line with the findings of our prevalence survey, showing that the elderly, especially the males, are being affected with TB. So this is another group of which we should focus on when you talk of interventions. The outcome, as I said, there's not much difference. They are almost a little bit the same. We don't have the 2016 outcome yet. This is something which we have been working on. But this is the data of 2014 and 15 treatment outcome. The active case finding of which I was referring to for the key PAPs, and mainly these are the mining community, the people who inject drugs, and also the people living with HIV. So you can, the most important thing in this graph is the difference of accessibility of services. When we talk of number of presumptive TB cases, the second set of bar from the left, they are still in the community. And then you send them to the facility, you get the number of presumptive TB cases tested. Now, for us, this is a measure of accessibility. This is where the males have been seen not to reach the facility. At least there's a huge number of females going to the facility, but the males tend to go back. They don't go to the facilities. Most of the reasons have been explained by my colleague from South Africa. This is a contact investigation. Again, it's part of active case finding. When we have a smear positive bacteriologically confirmed, we get the information of all contacts, and then we visit. People who visit this household are those community health workers or volunteers of whom we have trained. So these are the results. These are from January to June this year. Again, it shows that more females are more, easy, or they are ready to go to access the services than males. And most of the intervention has been whether we take the sputum at that particular household, or we invite that person to go to the health facility to get tested. The lessons learned, it's obvious that the monitoring tools are important in order to capture the gender in TB control. And this has helped us so far it has helped us to address some of the gender-related issues when it comes to when and how to implement the activities. The data demand, I put the word demand in brackets there. When it comes to really you want the data, put some legislation there so that you get it. And the utilization, of course, has been a challenge, but it has been a lesson learned for us that once you have this data, it informs you where to focus your resources, where to invest more to get more cases, and where can be the interventions which can provide more cases. Again, the last one is specific initiative targeting gender issues. TB has shown to have an impact on gender dimensions observed in TB programming. We would like to recommend a few things. There should be gender-specific programming to improve gender dynamics, to look into what the special needs of different populations. In this case, we can think of implementing of male-specific risk reduction intervention, or to improve the services at the health facility level to have specific or designated area for men. I don't know how feasible is that, but it's something which can be thought of. There's a need to have a country-level TB guidance materials and tools that address gender. And lastly, we need to strengthen the gender-sensitive integrated monitoring system, which will assist to identify and address gender-related specific barriers. What I can say in a conclusion is that we should not expect any different results if we don't change. So we need to change the mindset, we need to change the way we have been thinking so that we make a difference. I would like to acknowledge USID Washington and Country Mission, and also the KNCV Challenge TB country staff, and my colleagues who are in this session from the NTP. I would like to close with this one from the former president of the United States, he once said that change will not come if we wait for some other person or some other time. We are the ones we have been waiting for. We are the change that we seek. Thank you.
You could come to the microphone in the center, or I can bring one around to the sides. Yes, please. It's not working.
So my name's Bertie Squire from the School of Tropical Medicine in Liverpool, and I'm really grateful that this session has come to the Union. It's desperately needed, and it's really great to see the issues discussed and some actual action on the ground. But my question is, and you'll have to excuse me because I'm going to come with a little bit of a rant in a minute. How do we influence the way TB is discussed and presented in high-level discussions to ensure that the gender context is really accurately reflected? My experience is that the global narrative on gender is all about women. So a key manifestation of this currently is that the SDG on gender, Goal 5, is all about women. It says, achieve gender equality and empower all women and girls. And men and boys are not mentioned in a single one of the targets. This is very far from the concept of gender as being crucially about relationships between and among men, and very far from Jeremiah's concept of co-construction of our gender roles. I think this global narrative is really creating resistance to highlighting the facts that TB is essentially a male epidemic and requires a fully gender transformative approach. And I can give you 2 recent concrete examples of how this resistance is playing out. So in 2015 and 2016, the WHO Strategic and Technical Advisory Group meeting opened with videos, beautiful videos, but they actually represented women and children as the key vulnerable, key affected populations in TB control, despite WHO's own data showing to the contrary. And the second example is that the initial drafts of the Moscow Declaration have not mentioned men at all. In fact, again, represented women and children as the key vulnerable population. And efforts from myself and others to get wording about men into that declaration have met with considerable resistance. So I'm going to pose that question again. How do we influence the way TB is discussed and presented in high-level discussions that really ensures that this gender context is brought out? What I'm seeing here is great work at country level, but somehow, not coming through. So anybody on the panel who can help us get that going would be gratefully achieved.
Sure, I can share just a few comments about that. I do agree that it seems to be missing at the global level, and especially in broad documents and policies that seem to continue with the momentum from which they were created a decade or 2 ago. And it seems like that mindset hasn't quite changed. And similar to your example of the video focusing on women and girls, there are still many sectors of public health where gender equals women and girls. And we need to start to try to change that, and it will eventually trickle down to the communications people, but it's not there yet. And TB can perhaps help be a forefront in the effort to remind people that there's more to gender than just one side. In terms of influencing the high-level discussions, you know better than I do. One thing I would think that should be very powerful is when we look at the rates of TB, at who has TB, at what we need to do to bring that curve down to achieve the goals. We need to end transmission. We need to find the missing cases, and those are mostly men. Men make up 2/3 of those infected with TB. In order to really get at the epidemic, we need to find the men. So I think that would be quite compelling, even without the background of gender equality and health equity.
But the data are there, and somehow
Sorry.
it's still not being...
I just want to talk on the SDGs. To your point on the SDGs, there is, and it's in relation to gender-based violence, paragraph 20, they talk about engaging men and boys in support of eliminating violence against women and violence against men and boys as well. But the Men Engage Alliance, I would advise you to take a look at them. They're pushing for, because they still haven't developed the indicators that they need, so there's still room for discussion, I think. And there is a very real tension between and among the feminist community and Men Engage. And it's a good tension to have because there are limited resources and we do have a long way to go to reach to equal. But we do need to work together. And so this is an ongoing conversation, but it's so great to see you bring it up. And I think more of us need to bring it up when we are and we have that opportunity to be in those high-level discussions or even discuss it with our colleagues that are involved in those high-level discussions. So let's not forget about the opportunities we have to continue to bring it up as well. Yeah.
So I'm a little in over my head when it comes to Moscow declarations, but I'm just wondering, I mean, ostensibly, the countries that attend that will approve it, right? They'll vote and say, we buy into this. So, I mean, if we have civil society networks in some of these countries that are going, that can speak out and say, this is not okay. We're not okay with this statement and the focus on women and girls to the exclusion of men who we know are critical. I mean, maybe there's some mobilization that could be done there. I don't know. David, you would know better than I do. But that also might be really naive because I just don't know what the proper channels are for influencing this. I mean, I ranted to a very senior person at WHO about this very issue on Sunday. I have no idea if that will have any influence. But I mean, I think I would encourage all of you, especially those in the room who have links to civil society and who are going to be communicating with the delegations who go to Moscow to raise this issue. And I know there are a lot of issues to raise, but I think this one's really important. I mean, if this Moscow meeting is meant to really mobilize and move forward, and we're not acknowledging that this is an epidemic concentrated among men in country after country, place after place, then we haven't done a good job.
Hi, this is Amar from USAID India. Excellent presentations. I maybe particularly want to reflect on the Charlotte presentation on India slide, which is excellent observation. So put into that context, what I think that those kind of analysis brings to the further deep analysis. So what we did that and come to a conclusion that not conclusion, but the leading point is that what could be that why the early age and that females are more represented. So when we try to do that analysis, so private sector comes to be a particular area where it getting this result into. So since 2012, TB was made notifiable and we had this private notification upgoing. And so when we analyzed that separately, before 2012, the data was showing just like that, all age group, 37% proportion was female and 63% male. But now with the notification coming in, and for 2015 data, we almost had 200,000 notification from private sector, wherein the sex ratio was not that 37 to 63%. And particularly for the early age group, it was higher among females. So this brings to further, I think, research question on number one is stigma around people for going to the public sector, particularly with the girl child. And second, it also highlights the importance of having a case-based data at the country and district and the below level. Thanks.
Yeah, David Bratton with Results. Just to follow up on the interesting points, it's a really fascinating panel. Leading up to the draft declaration coming out of the WHO ministerial for this fall, there was a really very specific stream of advocacy work that came from civil society to say, here's what we want to see. I don't think this was reflected in that. And so as a practical suggestion, I think it would be important to communicate with the advocates who have been involved in that. GCTA, the Action Partnership, There's several others we could talk about. And I just had a question about and just one other quick point about that, which is that as advocates, we are in a of extremely competitive environment on global health advocacy. So it forces a lot of opportunism. I'm not sure that's going to change dramatically, but if the theme of women and girls is something that global leaders like Justin Trudeau are actually concerned and excited about, well, then we're going to have to talk about women and girls. Yeah, well, yeah, so it's definitely a challenge that we face as advocates. So the question that I had was kind of more about the U.S. government's resources as it addresses global health. I think probably the biggest source of funding is through PEPFAR, if I'm not mistaken. And I think that there's a significant amount of programming addressing men. I can think of medical male circumcision. I'm sure there's many others that I just can't think of off the top of my head. But I guess my question would be, has PEPFAR taken this concern on board? Because if they had, then one logical thing to do would be to, in this course of medical male circumcision programs, talk to the men about TB and the risk that they're facing. That would seem logical. So I guess my question is that happening? Because if that's where the investment is, and because the kind of changes that need to happen to take this really on are big. You have to start somewhere, but you would need to move big players like PEPFAR.
So I couldn't agree with you more, David. I think the challenge with PEPFAR is that is related to how much they're actually taking on TB, if that makes any sense. So we had an industry day last week before Guadalajara where we actually invited colleagues who are working on PEPFAR-funded programs dealing with VMMC, voluntary male medical circumcision, to talk to us about, well, how are you reaching these men? How are you approaching these men? Could we learn from that? And that's a great start, but I think that couldn't be addressed without also addressing the concern that it's really sometimes difficult. It's easier to get people interested in detecting TB among people living with HIV than it is to get people interested in detecting TB in the first place. And the struggle is real. So I completely agree with you, but I think that what you're saying we would also have to sort of mount let's also care about TB in the first place, and then also think about how we could build on these VMMC efforts to maybe promote TB screening, TB diagnosis. And it's great that we've started the conversation with them. But my personal concern would be that we would need to then get even more enthusiasm and support within PEPFAR for TB. I think we probably have to.
There might be another session starting. I see some other people coming in. Is there another session starting now? Can anyone confirm? If not, we can stay and chat. Okay. I have one more quick comment on that, in that the issue of men and health-seeking behavior is becoming more of an issue that also the malaria community wants to address. So PMI is interested in this. And I mean, we're still trying to get the conversation going, and amidst all priorities, try to figure out how to best move this forward, what are the interventions that work well, how to get messages out to men that are really salient and that have an impact. I think with this, if there's any last burning questions, we have to go. We did go over our time. But thank you very much for attending this, and it's been a great discussion. Yes, bye-bye.